Hello and welcome everyone to another Team FRCR 2P session. Um, a very big thanks to all our volunteers who have volunteered for today's session. So without wasting any further time, our first set of volunteers are Doctors Nuran and Vijaya. So Dr. Nuran would examine Vijaya first. Screen over to you, Dr. Nuran.
Okay, thank you. Hello, good afternoon for everybody, and I'm the first examiner. Is Dr. Vijaya is here?
Yeah,
Yes,
I'm here.
she is.
Okay, I will start with very clear and straightforward case. What is this?
Oh my God. Okay. So this is the frontal radiograph of hand, including the wrist and distal forearm. And there is shortening of fourth and fifth metacarpals.
Great.
And okay, there is mild physeal widening in the distal fourth metacarpal.
Okay, that's great. Now, what is the
Okay.
definition for the short fourth and fifth metacarpal, specifically the fourth one?
Okay, so other than that, I am not seeing anything, any other significant findings. So with the fourth and fifth metacarpal alone, I'll be thinking about the differentials like Turner syndrome, then pseudo hypoparathyroidism. Okay, and it can be a congenital deformity as well.
Okay.
So I'll be looking. Okay, I'll go for a proper clinical examination of the patient, and also I'll be discussing with the clinician regarding the presentation, and the case has to be referred to the rheumatology and further workup is needed.
Okay, lovely. I'll go to the next case. There are no clinical presentation, so I will click directly to the plain X-rays. These are the available ones.
Okay, so I'm provided with the pelvis radiograph, AP radiograph of pelvis of an elderly.
Male or female?
It's a female pelvis, and again I can see and I use intrauterine contraceptive device also in the pelvis. Then regarding the pelvic bones, there is an ill-defined lytic area involving the right sacral ala. I'm not able to see the ala margins clearly, and again some ill-defined lytic areas are seen in the superior as well as the inferior pubic rami on the right side.
Can you see something above in the upper part on the sacrum?
Upper part of sacrum, yeah, on the right side there is a lytic area. I'm not able to
Good.
appreciate the cortical margins.
Okay, do you want to see other films like this one, the hemipelvis and femur?
Okay, if other radiographs are available, I would like to have a look at them.
Okay, I'll continue to show you these also. Also the chest X-ray.
Okay. So the chest X-ray of this adult female, I can appreciate some pleural thickening along the bilateral hemithorax, and also there are some the ribs are appearing with expanded.
Okay,
yeah, at multiple locations.
Okay, so what do you see? This is not a pleural thickening. Just keep looking to the thoracic cage and the ribs and the scapula, if you can see something abnormal.
Yeah, the multiple ribs are also involved with expansile lytic lesions.
Okay, so what these all gives you, how an idea you can think of?
Yeah, basically, these are multiple expansile and lytic lesions involving the bones. So I'll be thinking about the differentials of expansile metastasis
Okay.
uh, or other conditions like myeloma, multiple myeloma, or basically these two differentials are coming to my mind right now. So again, I'll be looking at the any previous records, clinical records of the patient.
One of them was myeloma. What was the other one?
Metastasis.
Metastasis or myeloma. Okay, but just look to the sacrum. There is something like a surgical clips in the upper part on the right side, overlapping on the sacrum. So when there is such a surgical clip, what should you think of? So, patient must probably operated on something.
I can appreciate a single surgical clip on the right lower abdomen overlying the sacrum.
Yeah.
So, is it a renal transplant or?
Perfect. Lovely. So if you want, I can give you some MR pictures just to use the time perfectly. So.
Okay, so I can see the transplanted kidney in the right lower quadrant, and again, multiple expansile lytic lesions are there involving the pelvic bones. So probably the this is previous renal cell carcinoma operated.
Yeah.
Or it can be browns, or another differential I'll be thinking of as brown tumors. All these lesions are brown tumors.
Okay. Okay. Thank you. I will continue.
Okay.
No, I will leave this case. You did well in that one. So here also there is no such an important clinical picture. This is a frontal AP view of the wrist.
Okay, the frontal AP view of wrist.
Spotter diagnosis, if you can see.
Yeah, there is calcification of the triangular fibrocartilage.
Good. And what is the differential diagnosis for this?
So apart from that, I don't see anything obvious. So CPPD as the first differential I'll be considering here. Then again, other differentials, big gout or other crystal deposition diseases.
Okay. I'll go to the next one. This is with recurrent shoulder dislocation. And if you want, I will scroll to you these images. What are these images? Do you know?
Okay, these are the axial stir images of right shoulder joint in a patient presenting with recurrent shoulder dislocation. So I can see some flattening of the posterolateral aspect of right humeral head, and anteriorly the glenoid is showing some cortical irregularity, and the anterior labrum is appearing bulky and hyperintense, indicating a tear in the anterior labrum and underlying bony glenoid injury. So together with the clinical presentation of recurrent shoulder dislocation, I'll be thinking about Hill-Sachs deformity.
Okay, lovely. And do you recommend surgical approach or in the meeting, or it is not an indicative?
Yeah, this case needs a surgical intervention, and with the obtain findings, the patient need to be referred to the orthopedician.
Okay.
And
Actually, Bankert is there is no indication in the because it do heal by itself. But if there is very complicated cases, there may need some suturing. Okay.
Okay.
Yeah. Okay. So we'll continue. Well, this is there is a history of multiple genetic skeletal malformations in a 30-year female, male, and I will continue with this plain film, X-ray. Also spot diagnosis.
Okay, okay. There is acro-osteolysis.
Good.
And there is some resorption of the tuft of the fingers also.
Okay, lovely. So what is the differential diagnosis of acro-osteolysis?
Okay, so about the differentials, congenital conditions like pycnodysostoses, then it can be metabolic, including hyperparathyroidism, or it can be due to heavy metal poisoning. So based on the clinical scenario,
okay,
I'll be narrowing my differentials. And here, in addition to that, in the fourth metacarpal, I can see some periosteal reaction.
Okay.
Along the base of the fifth metacarpal.
Okay.
So I would like to obtain any history of trauma.
Okay, that's it. It's good.
Okay.
I will continue.
Dr. Nuran, we can make this the last case, I think.
Okay, okay.
Thank you.
Thank you too. So this is a 50 years old male with weight loss, anemia, fatigue, and you can have these images.
Okay, 50-year-old male with weight loss, anemia, and fatigue. So the provided with the frontal radiograph of skull, which shows multiple lytic lesions involving the calvareal bones as well as the mandible. Yes.
What do you think?
And these lesions appear punched out. So I'll be thinking about multiple myeloma as a first.
Okay. Can you give me some specific signs to differentiate between multiple myeloma and metastasis?
Yes, the mandibular involvement.
Okay.
Yes, in metastasis, the lesions will not be very well defined. They'll have a permeative pattern, whereas in multiple myeloma, there'll be the borders will be well defined and they'll appear like punched out lesions.
Good.
And apart from that, in metastasis, there will be involvement. Okay, there will be involvement of the mandible, whereas it's usually spared in multiple myeloma. I'm not sure if I'm right.
No, it is the contrary. The mandible is rarely involved in metastasis. It is mostly involved in multiple myeloma. And as you said, the lesions in multiple myeloma will be more discrete and small, uniform in size, as we see here in the skull. However, in metastasis, it will be a little bit different and heterogeneous in sizes, and it is not so well defined, and the endosteal lesions are not so well seen as in multiple myeloma. You did very well, Dr. Vijaya, and you reached the diagnosis of all of them. Good. Good luck to you.
Thank you. Thank you.
Okay, I will stop my screen.
Okay, thank you, Dr. Nuran. Excellent cases.
Thank you. Thank you.
The last one is the typical exam question.
Yeah.
So differentiation between metastases and myeloma. Dr. Vijaya, you can start sharing. And,
Dr. Vijaya, you confuse between that metastasis and myeloma.
Yes, I know.
So you can remember, like in multiple myeloma, there are 2 M's and mandible is M. So mandible is more involved in multiple myeloma.
Okay. Oh, thank you. Thank you so much. That's going to help me a lot.
Yeah.
Okay.
Now it's
And
my turn.
Yes, Dr. Vijaya, your turn to share the screen.
Okay.
Every
So,
second counts.
About that acro-osteolysis case, should we go for more differentials or
Well, it is better to give differentials. At least the top 3 differentials is important in Viva. That's why it gives you a little more chance to gain more points or more marks. I think so.
What was the diagnosis in that case, that acral osteolysis? What was the diagnosis?
Well, it is only acro-osteolysis, but maybe because of these peripheral periosteal reactions, it could be due to hyperparathyroidism or frostbite. I don't know. It is just written acro-osteolysis in Radiopedia.
There was subperiosteal resorption also that Vijaya pointed out.
I think it is more with hyperparathyroidism. You are right. Okay. So I think this is my first case, as it is shown in the screen. 4 years old female with limp. There is a AP view of plain X-ray of the lower extremity showing the femur. There is a lytic lesion in the diaphysis of the femur with a periosteal reaction. This leads me to think of an aggressive lesion in a 4 years old, and first of all, Ewing sarcoma, and as a differential diagnosis, I will think of osteomyelitis, osteosarcoma, or even eosinophilic granuloma. And I should, I need MRI, if possible, to see how long it is infiltrated within the bone marrow.
You want to go for orthogonal film or?
Okay, yeah, if there is, yeah, I will be happy to see other view. Yeah, there is a soft tissue swelling also around the lesion, but it is not so diffuse, it is localized. So I think this is mostly goes with a neoplastic process like Ewing sarcoma. And I would like to see to control the clinical picture of the patient, the white blood cells, CRP, if there is a possibility for infection, because infection also another aggressive lesion. This is one of the aggressive lesions, and my top is Ewing sarcoma. Unless the clinical and laboratory tests keeps with infection. And in such case, I recommend or suggest imaging the whole extremity to see if there is any possibility for skip lesion in the other bones, and for grading, of course, from the point of view of Ewing sarcoma. And also chest X-ray if it is osteosarcomas, to rule out the possibility of metastasis to the chest.
Okay, so I'll go for the next one.
Yes, please. Is this the next one?
Yeah, this is the second one.
Okay. Well, this is frontal chest X-ray of lower extremity of the foreleg and ankle joint. I'm looking to the long bones and to the cortex. It looks intact. There is nothing obvious in the medullary lesions of both tibia and fibula. I can see.
He's a 20-year-old with leg pain, okay?
30 years old.
20,
okay. Well, is there any orthogonal view just to help me to see if there is, because I can't see any cortical thickening or any lesion in the, yeah. Well, I think there is some subtle cortical thickening in the lower part of the tibia. And because of pain in 20 years old, it keeps me to think of, first of all, of osteoid osteoma. And I will like to ask the patient if the type of pain comes with at night, and if it goes with salicylate or aspirin, just to be sure of my diagnosis. And
actually, he has pain on both legs, and he's an athlete.
Okay, he's athlete. So there is also another possibility of stress fracture because of he's using his legs too much. So maybe these cortical thickenings is due to stress fractures from using them a lot. I can see something else in the surrounding soft tissue or in the ankle joint. Just these thickenings. It could be due to stress fractures. Okay.
Okay. So
This
this
is
is the MRI for the same patient.
Yeah, well, is it only this one, or can we scroll it a little bit? Because
No, actually, I have only one image.
okay, well, there is a surrounding linear hyperintensity. This is, I think, yeah, okay. There is a bone edema and surrounding hyperintensity around the tibia. Well, in 20 years old athlete, it could be stress fracture or contusion of the bone in my top differential. However, I can't exclude osteoid osteoma, and I need, if possible, CT or more clinical picture. But I think this is a stress fracture with edema.
Okay.
Okay, thank you.
So does this help you?
Okay, there is focal uptake in this bone scan of the lower extremity. Yes, there is a focal uptake here. Well, yeah, this is again keeps me think of again with either osteoid osteoma or fracture with periosteal reaction.
And there is another finding that will help you to narrow down between the two differentials you're saying. This medial tibial stress syndrome and osteoid.
Yeah, there is another uptake in the upper part of the tibia, but this is tibial tuberosity, no. Well,
Okay.
soft tissue swelling and linear periosteal reaction, these are all can be seen in both situations. Yeah,
Okay.
the other leg is also affected.
Yeah, there you are.
Yeah, there is linear periosteal reaction. So I think this is most probably due to stress fracture because he's
Okay.
using his legs too much. Thank you.
Okay.
Okay.
Okay. Your third case.
Yeah, third case. This is a coronal view of T2 weighted fat suppressed sequence MRI images. There is a fluid, pleural effusion in the glenohumeral joint. Well, there is some degenerative subchondral changes in the head of the humerus. How old is this patient?
Elderly, actually.
Elderly. Okay, I think the supraspinatus tendon is thinned. However, I would like to have a sagittal or axial images to be sure, or other images. Yeah. Well, there is erosive changes in the head of the humerus with pleural effusion, and the supraspinatus tendon looks very thin, maybe injured or teared. Is it female patient or male?
The female patient, elderly female with a chronic shoulder pain.
Yeah, I would like to discuss this case with the clinician and to know the clinical picture if it is progressing so quickly, because there is a possibility of Milwaukee syndrome here, because there is destructive erosive changes in the head of the humerus with effusion. However, if there is no such probability, so this is supraspinatus injury with pleural effusion and degenerative changes. If you have another image,
You mean a joint effusion?
Joint effusion with and there is erosive changes in the head of the humerus.
Okay.
Yeah.
So can you tell few differentials or not two differentials?
Yeah,
that
there
you'll
is.
consider here?
Yeah, it could be possible. There is possibility of Milwaukee syndrome, or even in rheumatoid arthritis in the elderly patient. There we can see such because it is synovial joint, and also in a degenerative process like supraspinatus lesion with the fluid. Yeah.
So the same findings here also.
Yeah, in T1 weighted images with the fluid, but the fluid intensity looks a little bit bright here. It is T1 weighted images. Oh, wow.
Okay, so we'll go to the next case.
Okay. This is
Okay.
AP view of chest X-ray. I'd like to see, the mediastinum looks normal and the diaphragm are not remarkable. I would look to the, because it is MSK session, I'm starting with the thoracic cage first, looking to the clavicles.
Yeah, actually, I I put this film by mistake. Initially, I thought this is an MSK film, but later
You
it's not
discuss,
purely MSK. Okay, so maybe I can skip this case, or you just want to go for this?
No, go
well,
ahead. It's okay.
yeah,
Okay.
it's okay. Well, there is I can see a central line in this patient extending down, but I can see the end of it. And there is
Right.
um, uh, there is no specific findings in the thoracic cage, but there is no pleural effusion. However, there is some low density in the lower zone, maybe due
Right.
to gas. So, yeah, either pneumothorax or something protruding, projecting over the lower zone. So I need other lateral view or even
Okay, so your findings are right.
yeah,
There is lucency right lower zone that
yeah,
is extending to the chest wall. So
yeah.
and also there is central line.
Okay.
So apart from that, do you see any other prominent findings? Any
Well,
surgical clips or anything of the sort?
well, yeah, I think there is some surgical clips on the right axilla or on the right chest wall. No, in the
Yeah, there
left
is.
one. Yeah, in the left also there is some here surgical clips.
Right.
Yeah, so I think.
So these are basically. Go
Yeah.
ahead.
Well,
I'm
maybe.
so sorry to interrupt. Just to let you know that case 4 would be our last case. Go ahead.
Okay, thank you. So maybe because of these.
Okay, so I'll rush through this.
Okay, please.
This another one, same findings.
Yeah.
Just to make the findings more obvious.
Yeah, now
So,
the mediastinum is shift a little bit more. I think this is pneumothorax, yeah, with something beneath
okay,
the
this
lung.
this is a difficult case. This just to correlate the CT and the X-ray. So
Okay.
basically, the lucency that you found out in the right lower zone, it's a pneumothorax only. So this basically a surgical procedure that's a Claget's thoracoplasty done for chronic empyema. Okay, what you're seeing here is a marker gauze.
Okay, okay.
Kept here, and that is what we saw in the X-ray also.
And
That the
why,
lucency was till the chest wall.
what was the cause of the pneumothorax here in this case? Is it because of the tube?
No, it's
What is the procedure name?
post surgical. Yeah, right.
Or
Procedure
surgical?
name called? What is the procedure name? What thoracoplasty?
It's a Claget's thoracoplasty. I'll tell you the spelling later, maybe.
Okay.
Okay. Do I have time for one more case?
Okay.
It's the last one.
Okay, go ahead.
Okay, this is a frontal chest X-ray of the shoulder. I can see there is an increased density in the right hemithorax, specifically in the perihilar region, extending to the periphery. So it gives me the possibility of chest or lung CA. And I would like to look to the bony cage. I can't see anything unless there is some increased density in the clavicle, in the right clavicle, and but there is no lytic lesions in the humerus or scapula.
Okay. Can you concentrate on the clavicle a bit more?
Yes, the clavicle looks little, yeah, oh, there is a fracture in the medial part of the clavicle, and beneath the fracture there is irregularity or radiolucency. It could be a pathological fracture, and with such a mass, I should think of metastatic lesion to the clavicle with a pathological fracture due to chest or lung CA.
Okay, right. This is basically a lytic lesion causing pathological fracture along the medial 1/3 of the clavicle
Yes.
with lung mass. Okay, so
Thank
the
you.
diagnosis that you have reached here is correct.
Thank you.
And
Typical exam case. Thank you.
so this one was just to correlate between the X-ray and the CT findings.
Okay. Lovely.
So this is the differentials that you have told are right. This is basically a case of rheumatoid arthritis. And here you can see multiple erosions,
Yeah.
basically an erosive arthropathy in an elderly patient, and there is joint effusion,
Good.
synovial thickening. So this is a case of rheumatoid shoulder.
Lovely.
And actually this case was basically put with two intentions.
Yeah.
The first is if one film that you are provided initially turns out to be normal, that means you are not able to find out any obvious abnormality, you ask for the orthogonal one, okay, that you rightly did.
Yeah.
So you could pick up the periosteal reaction in the orthogonal view alone. Then we are considering two differentials, osteoid-osteoma and this stress syndrome. So MRI is not that yielding because I did not provide the whole set of images. So again, in the nuclear scan, actually the opposite limb is also showing periosteal reaction along the cortex.
Okay.
So that actually helps you to narrow down the differential to stress syndrome, because osteoid-osteoma does not occur symmetrically on both tibia, right?
Yeah, you're
So
right.
again, you were right with this diagnosis. So the first case, this is basically the description was very good. This is a lesion, permeative lytic lesion involving the diaphysis of femur with periosteal reaction. So there is no pathological fracture associated. So differentials you considered were Ewing sarcoma, then also osteosarcoma, then eosinophilic granuloma, right?
Yeah.
Yeah.
And
So
is there possibility for infection also in the differential diagnosis? Because
definitely,
Okay.
there is a osteomyelitis is also a differential.
Okay, thank you.
Okay, just a
So-
few points. If my sorry, go ahead, Dr. Vijaya.
Yeah, that's it. The cases are all
Okay,
right.
thank you.
Yeah.
Excellent cases, excellent cases. Just a few points I would like to add. Whenever we are going for the sarcoma case, we have to practice saying the words, refer to sarcoma center, biopsy to be
Right,
done
right.
by the sarcoma center, MRI to see the skip lesions, and the chest CT for staging, just for the sake of it. Personally, I might be wrong, but I would not put eosinophilic granuloma here because it looks aggressive. So I think Ewing's and osteomyelitis are fair enough differentials. And regarding the last case of the shoulder case, once we say that there is a suspected chest lesion, always we have to say out the next step. The next step is chest X-ray. Of course, it's something which is understood, but the examiner would like to hear the words, right? Because this is a shoulder X-ray. These are the only things which I wanted to say. Thank you so much.
Can I add someone on the chest also?
Sure.
It is. I missed that. I forget to tell that also. When we see a lung CA, we will discuss it in MDT, and we will book within the 2 weeks, the most shorter time on CT, because there is a possibility for lung CA and bronchoscopy biopsy. These all should be discussed on MDT. We should all mention
No,
that.
actually, if it is a new finding, then you have to do a chest, abdomen, and pelvis staging CT and refer it to the MDT.
Correct.
Yes.
Yeah.
Okay.
Okay. So Dr. Mehvish and Dr. Saneej, you guys are next.
And in that eosinophilic granuloma case, as Sabahat told, there is no osteoid matrix. So the eosinophilic granuloma, the Ewing sarcoma and the osteomyelitis comes first. All are seconds. All will come later. Those are the first.
We should not say osteosarcoma here, no? First.
The age group is not fitting, and so the osteoid matrix is not there.
Okay. Actually, they have given differentials, Ewing's, then LCH. These two differentials were given in Radiopedia. And of course, osteomyelitis comes as a differential.
LCH and osteomyelitis are fine. Yeah.
Well, to tell, sorry for interruption, but speaking as an aggressive lesion, starting with aggressive lesion, then giving the differential diagnosis is the right thing, because it is a criteria of aggressive lesion, lytic with periosteal lamellated reaction and soft tissue swelling. And then you start according to the age and clinical picture to say if it is Ewing's, osteosarcoma, or infection.
Perfect. Thank you so much.
Thank you, too.
I'll stop sharing.
Yes, please. Thank you. Mehvish?
So Sabahat, who
Yeah,
is
yeah.
Let Mehvish first grill you, then you can grill Mehvish.
No, I think you let him grill me. I'm very scared from Dr. Saneej. He's given me nightmares at night.
Okay, anyone, go ahead. We are running 5 minutes late. Go ahead.
Okay.
Okay, no
Dr.
problem.
Saneej, you start first.
Yeah, it's a very simple case. You have to start speaking so that you can see many cases. Okay.
Okay. So this is, I'm given a radiograph of the ankle, of the left ankle of a man who's suffered a fall, in which I can see that there's a lucent lesion in the calcaneum within a speck of calcification inside. There's no periosteal reaction. There's a thin sclerotic border. And keeping the differentials, my differential would be intraosseous lipoma, or it could be the second would be I forgot the name, but there are 2, 3 anyway. Okay, so the second is there's a 25-year-old female with heel pain for weeks, and there's no history of trauma. Okay, this is again a radiograph of the right ankle, in which I do not see any. Can I have another view, an orthogonal view?
You have to say the findings here.
Anyway. I can see a
the
mild
findings
periosteal.
in the given view. You have to tell the findings in the given
Okay.
view, and then you have to earn the other view.
Okay, and I can see few. It's heel pain. I see mild periosteal reaction in the calcaneum. That's all I can see. Can I have another view? I just see a mild periosteal reaction. That's all I can see in this. And with heel pain.
Where
Does this
is
happen
the periosteal reaction? Which area? Where is the periosteal reaction? Here?
Calcaneum. Yes, up above on the upper end.
No other findings?
Why do this is stenitis or with the attachment of the tendon? Probably.
So what will you do?
I would want an MRI.
Why you want an MRI? What are you suspecting?
I would like to see the tendons. Reactive, usually the ones that calcaneum is reactive, arthritis or some, reactive.
You are suspecting a soft tissue pathology or a bone pathology?
Soft tissue with bone.
Okay.
Dr. Saneej just kept all the heel pains for me.
34-year-old man.
34-year-old man. Okay, so this is this is a 34-year-old male, a radiograph of 34 male in which there's an periosteal reaction noted along the posterior aspect of the calcaneum, and calcaneum and the heel. So keeping in view, this would be, and also along the talus. This is a reactive arthritis because there's small erosions. There are erosions and periosteal reaction along the calcaneum. Severe pain at the back of heel, right, greater than the left. Okay, so this is a
This is the right, this is the left.
Both radiographs.
Patient has pain on the right side.
But in which I can see there's more soft tissue thickening on the heels.
Which part of the heel? Which area of the heel?
I think the dorsal side.
Here?
Yeah, plantar. Sorry, yeah, the plantar, and yes.
You want to compare it to the left?
Yes. Is this thickening on both sides, but it's more on the right?
Where is the thickness? Here or which area are you saying? Like, is it in the plantar aspect or in
The outside one, this one.
is it in the plantar aspect? Is it the posterior aspect or anterior aspect?
The plantar aspect, no?
Plantar
Posterior
aspect.
and the, yeah.
Plantar aspect, no. Okay. Okay.
Is it MSK? Okay, this is a chest radiograph of an adult in which I can see that there's a lucent lesion in the humeral left humerus, and there's could I zoom this, because in my image it's coming a bit small. Let me see.
You can go to you can go to that view options and select the zoom to 50%, 100%, whatever you like.
Oh yeah, yeah. Yeah, there's a lesion in the right head of the right humerus, as well as the glenoid cavity. There's also resorption of the distal end of the clavicle.
No.
And lytic, but there's a lucent lesion in the humerus, the right.
No.
No.
So this one.
Is there any history? Oh, what's
This
going
patient
on?
came with hip pain, right hip pain.
This patient came with right hand. There is avulsion of the this is a pelvis X radiograph, which I can see that there's avulsion of the left anterior superior iliac spine.
Yeah, that is old one. That's old one. You can see the well corticated margin. Yeah, ignore that.
Okay. He came with left hip pain, right hip pain, any hip pain, and there's also sclerosis.
Right hip
I can
pain.
also see. Okay. I can also see there is sclerosis in the humeral head.
Okay.
Right. Sorry, femoral head. There's sclerosis and with asymmetric joint space narrowing, and there's sclerosis of the head.
Okay.
And there is sclerosis, is joint space narrowing. So this would be, does the patient have history of steroid intake?
You have to find out that.
Okay, I had to find out. So this would be, it's an elderly man.
Yeah, it's an elderly man, yeah.
Yeah. And there are also these soft tissue calcifications. These soft tissue calcifications that are coming inside around the soft tissues.
What are those?
The calcinosis.
Pardon?
So this would be, this is soft tissue calcinosis or dermatomyositis.
Okay, so
will
the patient take steroids for that?
Yeah, the patient may be taking.
Okay.
Oh, do I need? Do you have any other view? Okay.
You have to tell the finding in that view, and then you have to earn the other view. Like you should not ask me for other view all the time. You have to tell the finding of this view.
Okay.
And then you have to earn the other view.
Okay. This is somebody one who presented with the heel pain. I can see that there is a sclerotic lesion with a lucent lesion in the lateral aspect of the tibia and the metaphysis of the tibia.
You can see the both knee.
With the sclerotic, with the okay, I can see that there's a prosteal, diffuse, lamellated, permeative pattern in both knees.
Permeative pattern.
Yeah.
Okay.
Posteromedial knee pain.
Okay, I'll move for you. The ligaments and menisci are normal. Patient came with medial knee pain. Which sequence you need? Which coronal, sagittal, axial?
I would see the sagittal first, and then I'll go for the coronal. But I can see right now there's fluid in the suprapatellar region.
You need sagittal.
Yes.
Yeah, that's a
yeah,
normal finding. You can ignore that.
No, and there's also bone bruise and edema seen in the patella. And I can also see bone bruise edema in the patella. And could you?
No bone bruise. Yeah, this is actually some. You ignore
What's
that.
coming down, the one that's coming under this one.
You ignore that. Yeah.
Okay. Can I see the ACL and PCL please a bit slowly?
You have to concentrate on the history given. History given was posteromedial knee pain, and the examiner told you that the ligaments and the menisci are normal. Okay.
Okay, posteromedial pain. Can I have an exit?
Next one.
Oh yeah, next one.
1 second. I don't know. I have a case next. 1 second. Yeah.
Oh, this is a radiograph of the knee joint in which I can see that there's an avulsion of the medial end of the tibial condyle, and there's no joint space narrowing. And there's also, there's just this. That's not a perosteal reaction around that, I think. There's an avulsion injury of the medial tibial condyle. Is it
okay, which ligament is avulsed?
Medial collateral ligament.
What will you do?
I would refer this to I would get an MRI done to see the other ligaments first. No?
Why you are doing an MRI?
To see if there is bone bruise edema also.
Okay. What is the implication of bone bruise and edema in clinically?
Sorry?
What is the clinical implication of bone bruise and edema?
Nothing. So I would just wanted to get to look how the extent of injury of the soft tissues and the ligaments.
What are you expecting? What ligament injury you are expecting apart from MCL?
The insertion of muscles.
Dr. Saneej, can we make this the last case?
Oh, okay, this one or the next one?
Yes, the last one, if possible. Okay, go ahead. If you want to show this one, go ahead.
No problem. I'm running out of cases.
Let's put Mehvish out of her misery.
To show me, yes, he showed me all the knees and the heels of the world.
Actually, Mehvish, I just tried to be the real exam scenario.
Yes, excellent. Yes, that's how it is.
Oh my God, Dr. Saneej showed me all the heels and all the knees.
I can see Mehvish crying there. Sorry, apologies.
It's already.
Okay.
Excellent cases and excellent examiner role, Dr. Saneej. And Mehvish, don't worry, you did amazing. So no worries. Go ahead, Dr. Saneej, with the feedback.
He showed me all the ankles. Oh,
okay, you are correct. Like there is an avulsed bone flake noted adjacent to the medial tibial condyle. So you have to tell you should not stop there. You have to tell it's a reverse second fracture. And it suggests disruption it suggests disruption of medial collateral ligament. But in addition to that, I am suspecting injury to the medial meniscus and PCL. So it's usually associated with PCL and medial meniscal injury. So I need an MRI. So you have to validate why you are asking for an MRI. and you have to refer them to the orthopedicians. Okay.
Yeah.
Okay, then this one you have
This
to
was
keep.
this.
Yeah, you have to keep an eye to what the examiner is saying, like posteromedial knee pain and suspected meniscal injury. And when the MRI was shown, I clearly told you that menisci and the ligaments are normal. So that's a hint that is helping you to concentrate on other structures. Like here you can see
The
fluid
cystic.
here,
Yeah.
fluid here.
Yeah.
So this is pescancerine tendons like semimembranosus, gracilis, and
Yes.
that,
Yes. Yes.
that
Yes.
three
Yes.
tendons. So there is a bursa here,
Yeah.
pescancerine bursa. So that is typical appearance of pescancerine bursitis. That typical three tendons coming and fluid. So usually you can conservatively manage, or sometimes they will ask you to inject steroid and local anesthetic in that pescancerine bursa by ultrasound guided. So that also you can say. So that's done by radiologists. And this is a pain after right knee strain. So
Right knee
you
strain.
told that it's a permeative lytic lesion. So then suddenly the X-ray will go, because it's a do not touch benign lesion, bilaterally symmetrical.
Yes.
So once you tell like an aggressive lesion, then that's a you are an unsafe radiologist. So the X-ray will go down, because there are no fractures. Patient came after a history of trauma, but there are regular linear bands of radio opacity extending vertically from the metaphysis into the diaphysis of the femur, tibia and fibula. So they are bilaterally symmetrical. So that is benign, and that is called as osteopathia striata. So
yes.
nothing to do.
Correct.
Okay. Then this one actually you correctly spotted it. Like there is an avascular necrosis of right femoral head with steroid therapy. So steroid therapy patient is suffering from a chronic disease called dermatomyositis. So it's a story case like dermatomyositis and avascular necrosis. So you have to assume that the patient is taking steroid. That's why avascular necrosis came. It's a story, Philip. Okay.
Okay.
Then this one also is a benign incidental finding. So when you describe it as an aggressive lesion, then the film will go down. Like it's a sprungal deformity. You have to tell like there is an elevation of the left scapula in keeping with the sprungal deformity. Then I am checking for any omovertebral bone. There is no omovertebral bone. But I am also looking for any vertebral anomalies that is also associated. I am not seeing any vertebral anomalies. So I'll compare the previous films, and if it is stable, then nothing to do. The film will go down. Okay. Then this one actually is a combined case, like pain at the back of the heel, right greater than the left. So to compare the both right and left. So here there is a bony projection here, and you can see this is convex here, and there is soft tissue swelling here. You can compare here. It is concave here, and there is some thickening of the Achilles tendon, but it is concave. And you can see the Kager fat pad is very clear, and you can see here on the right side, the Kager fat pad is ill-defined, and there is retrocalcaneal bursitis, there is Achilles tendinitis, and here this is called Haglund deformity. Haglund deformity of the calcaneum. So there is surrounding soft tissue edema, insertional Achilles tendinosis, retrocalcaneal bursitis. So you can either suggest a ultrasound, or you can either suggest an MRI. So this is this is not the same case, but MRI where you can see that the Achilles tendon is enlarged. There is retrocalcaneal fluid in the Kagan's bursa, and also there is edema in the calcaneum here. Okay, so that is Haglund
deformity.
Haglund deformity with Haglund syndrome. And this one Actually, heel pain in a 34-year-old, you spotted it correctly. Like there is an erosion here at the insertion of the Achilles tendon with you can see the erosions. And I'm not seeing any thickening and any other findings. Like then you correctly told that you are suspecting reactive arthritis. You can just tell that I'll check whether this patient had any genitourinary or gastrointestinal infection in the preceding weeks.
Okay.
So that will add you more points. Like that is usually associated like 1 to 6 weeks before the patient will have usually gastrointestinal or genitourinary infection. So there's a small spur here. Then bone density is preserved. There is some sclerosis and erosions. So that is a reactive arthritis. And this was heel pain for weeks, no history of trauma, 25-year-old female. So here you can see a sclerotic line here in the calcaneum. So this is a typical appearance of a stress fracture of the calcaneum. So here you can see this is a typical appearance of stress fracture of the calcaneum in a young patient. So you can either suggest an MRI or a bone scan. Here the bone scan, you can see the increased uptake, but it will be shown only if you raise the possibility of a stress fracture.
Okay.
Then this one is an ankle trauma due to falling. Is a very small, is a beginning case, like warm up case. Just say that there is a loosen lesion with the well-defined margin and the central dot or cocktail. So the sign is called cockade sign or something. COCKAYD, cockade sign. It's a calcaneal lipoma. It's a typical location of lipoma after the femoral neck region. Okay. Thank you.
Okay. Thank you, Dr. Saneej. Very good cases.
Okay, thank you. Dr. Mehvish, share your screen.
Yes,
we have 5 more hot seats to go, and we have got 60 minutes, 63 minutes. So I'm making the hot seat 10 minutes each so that we can accommodate all. Go ahead, Dr. Mehvish.
I am sharing this, checking my... Dr. Saneej, you don't need to worry. I am a very nice examiner. I won't do what you did with me.
So this is incidental finding detected by radiography after car accident.
Yeah.
So there is a well-defined loosened lesion at the metaphyseal region of tibia. I am seeing it in the frontal radiograph. So in my usual practice, this lesion I will compare it with the lateral radiograph also. It's a benign appearing lesion with I'm not seeing it in the lateral view. I will go again in the frontal view. So in a young patient, I'm thinking the possibility of a benign lesion like fiber. I'm not seeing any matrix here. It can be a fibrous cortical defect. So I'll compare the previous films if available, and if it is stable, then it's a do not touch lesion, and I will inform this to the referring clinician.
Good. Okay.
So post minor trauma, 35-year-old male, post minor trauma.
Something is happening to me.
This is a pelvic radiograph of a 35-year-old with a post minor trauma. I am looking at the sacroiliac joints. There are some minor sclerosis, and I am looking at the pelvis. There is some facet joint arthropathy. I am looking at the femoral heads. There is a loosened lesion with the sclerotic borders at the femoral neck region on the right side. So I'm looking for any fractures or any dislocations. superior pubic ramus and femoral neck region. So this lesion could be a benign lesion like a synovial pit, or it can be a bone island, but bone island will be dense lesions. So I'll compare the previous images, and if it is stable, then this could be a benign synovial pit or something. I'm not. I don't remember the exact name. Yeah.
Pit.
You are clicking the right button. You can click the left mouse button. That's why that coming.
Yeah. I just have one button. I don't have another one. Okay. So
History of
this is
swelling
your
of
other
the
case.
third digit of the right hand for 6 years. History of swelling of the third digit of the right hand for 6 years. 30-year-old male. So this is a frontal radiograph of the right hand. There is a large soft tissue swelling involving the middle finger. That there is destruction of the phalanx. There is also a loosened lesion involving the proximal phalanx with bone expansion, cortical break, a periosteal reaction, and the other bones looks okay. So I look at the other views in my usual practice, and there is a large associated soft tissue component. This is a aggressive lesion, malignant lesion with bone destruction and soft tissue component. So this could be if it is a known case of malignancy, it can be metastasis, but unlikely that will come in that such distal
incidental finding.
So it's an incidental
finding. Yeah.
So it can be a tumor from the soft tissues, like it can be a sarcoma from there are multiple soft tissues, like it can arise from blood vessels, it can arise from muscles, or it can arise from bone.
What would you want to do next?
I'll do an MRI to see any. So here, this is a coronal T2 fat site image. So I can see a large soft tissue that is arising from the tip of the third finger with the soft tissue component. I look at the contrast in images. There is some significant contrast enhancement I can see. The T1, I look at the other sequences like T2, and this is actually a aggressive sarcoma, like sarcoma. In this age group, it can be synovial sarcoma. It's a elderly age group, or it can be Ewing sarcoma is seen more in the younger age group, but it can extend to this age group also. But it's not a bone forming osteosarcoma, but it's definitely this needs to be referred to the sarcoma center for further evaluation and management and MDT discussion.
Okay.
So fall on outstretched hand, football game followed by severe pain, swelling, and limitation of movement. 21-year-old male.
This is an easy one.
21-year-old male with fallen and outstretched hand. It's a MRI coronal T1 weighted image where I can see there is diffuse hypointensity involving the scaphoid bone. The normal marrow hyperintensity is lost, and I'm looking at the scapholone at distance. I'm also looking at the ligaments, and other bones looks fine. So this maybe the patient had a previous fracture. I can see some fracture line going through the waist of the scaphoid. So that is maybe previous scaphoid fracture causing avascular necrosis. But I am also looking for any. I look at the other sequences for any signs of any instability, like sagittal T2, for any VC or DC.
Yeah. Okay.
The ulna looks Oh, okay, sorry, not ulna. The
Yeah,
lunate
next
looks
to it.
oriented towards the dorsal. It looks like a DC.
Yeah, yeah.
Mechanical fall with the popping sound in ankle, right medial angle tenderness, tenderness in right fibula head, right medial angle tenderness, tenderness in right fibular head. So I can see there's a frontal radiograph of entire leg, including the ankle and knee. So I can see there is a fracture line at the medial malleolus, and so when I see a fracture line in the medial malleolus, I'll look for a fracture of fibula. I can
Do you want
see
another view?
Yeah, I'll look at the other view. So it can be associated with a proximal fibular fracture. Yeah, there is a proximal fibular fracture. So it is. It's either called. There is a name for this fracture. Medial malleolus. It's a Maimoona fracture. M for my.
Yeah, Maimoona fracture. Yeah.
So Sabahat, time over?
No,
1
Dr.
minute,
Saneej, you have
24
time.
seconds.
Don't worry. Let me find you a nice case, Dr. Saneej. I need to be nice to you.
Nice in inverted commas.
Yes. Okay, Dr. Saneej, let's do this.
Okay. So this is a 4-week
can-
facial numbness, 25-year-old female. 4 weeks of facial numbness, 25 weeks, 25 years female. Okay.
Yeah.
So this is
which sequence do you want?
First, I will see the T1 weighted. Axial T1 weighted image. I can see an extra axial mass with a heterogeneous appearance in the compressing the brainstem, and that is hypoindents in T1. There are multiple foci of hypointensity in that lesion. So I will see the T2 weighted images. So in the T2 weighted, again, that is having a heterogeneous appearance with a multiple area of hyperintensity and what?
Where is it? You didn't tell me the location.
Yeah, that is in the that is anterior to the mid. That is an extraaxial location between the medial part of the temporal lobe and the anterior to the midbrain. That is causing compression of the midbrain and pons. So I look at the contrast images. I think it's a contrast enhancing. In the
do you want a contrast enhanced?
And if there is any sagittal or coronal images, I would like to see whether it is originating.
I can show you coronal.
In the coronal, it's peripherally enhancing and it is compressing. The origin of the tumor. So I'll compare with any previous images and any CT if available. It would be. I'll compare the CT.
Can you see
also.
the cavernous sinus?
Cavernous sinus. I'm looking at the ICA. I'm tracing that ICA up, and that is the cavernous sinus is compressed. The right cavernous sinus is compressed. That is maybe that is compressing the cavernous sinus. But there is not much brain edema seen, so this could be the appearance. It seems like there are some calcifications. I will see any SWA images to look for any calcifications.
You want which image?
The SWA images, like last sequence.
The diffusion, SW. Okay.
Susceptibility weighted image. There is susceptibility artifact, so definitely that lesion is calcified. So it could be a calcified lesion. It can arise from in that location. There is a chordoma. There is a
chordoma.
Like chordoma or any aggressive.
Chordoma is central.
It can be an aggressive variety of a chondroid tumor. Like if it's an elderly patient, it can be I think this patient is 60-year-old or something. Can be chondrosarcoma.
Sorry. Yeah.
25 year.
We
Then
are,
Oh, yeah. I just.
yeah, finished. We are finished with time as well. So go ahead with the
Okay, here's the CT also. Okay, but there's a CT also. Now you can see it.
yeah, there is some
And the
calcification.
CT.
This could be a bone tumor, like with the chondroid matrix.
Yeah.
But I don't think it's a
Yeah.
chondrosarcoma. Maybe, I don't know.
It's a chondrosarcoma actually.
Chondrosarcoma will come.
Yeah,
will
because the
come-
chordoma usually arises from the clivus. And
Okay.
it's central. This is not central. Chondrosarcoma always arises on the side. It's very usually it's not on central. So this
But
is
25 years, chondrosarcoma is not the age group of 25 years. I don't know.
yeah, but this was the
Okay.
chondrosarcoma. It's biopsy proven, and it's
Okay.
usually on the side. This is not it. But you did very well, Dr. Saneej. You should be in
Means,
RCR as an examiner.
Okay.
you
Thank you
should
for
be in
being a nice
RCR.
examiner.
No, you should be in RCR. You were a very good examiner. Thank you.
Yeah, I just tried to just give a real examination picture. That's all. Thank you.
No, it was very good. I think I think diagnose. Oh, this is left, but you diagnosed the cases all very well. So I don't think I need to go over them.
Oh, all are correct.
Yeah. Do you want to go over them? Because I
don't
think you
know.
diagnosed all of them. This was mass news fracture. This was mass news fracture.
Okay.
And then we had.
Usually in Maimoona fracture, they will show only the angle, and then you have to ask for the X-ray of the upper fibula.
Yeah, orthogonal view. Yes.
No orthogonal view. You have to ask for.
And this was avian of the scaphoid. This was avian of the scaphoid with dorsal subluxation.
Yeah.
So, and then we had, this was Ewing sarcoma. The hand of the first 6 years, this turned out to be Ewing's. But your differentials were fine. Yeah, it was biopsy proven to be Ewing's. Even though it's not the age, I think it was in 20s, but this was Ewing's.
Okay.
Surprisingly, now we are also getting things like which were written like if first in our textbooks it's written ATRT does not happen beyond 2 years, but we have seen a lot of kids with ATRT presenting at 15 years, 11, 12 years, and all this. So usually age is not. I don't know. Maybe in our practice now, age is not an issue. And this was the post. Oh, this was a pit spit. It's known as pit spit. So yeah, this was fine. So you did very well. I think you can take the exam now.
Okay.
Okay. Thank you so much, Dr. Saneej and Dr. Mehvish. If you could stop sharing the screen, Dr. Mehvish, Laila and I can go ahead.
Yes.
Laila, go ahead. Share your screen. You take my Viva first. I'll take your Viva next.
I share my screen first.
Yeah, I can see your name. You still have to share your screen.
Okay. Okay. So, Dr. Sabahat, you want remote control?
Yes, please. And I'm starting the timer.
Okay.
Okay, thank you. So these are multi-sequential MR images of the knee. I would like to start with the sagittal first. So I'm having first go through the sagittal proton density images, which is still loading. I should have gone for the one which was first. Okay. So I'm going through the tibiofemoral aspect of the knee joint. As I'm scrolling, the PCL is intact. The ACL appears a bit thickened, and actually it shows a sort of linear hyper intense signals. I would like to see further imaging. Which one should I take? Okay. For a moment, I feel that this is the celeristic appearance of the anterior cruciate ligament. So I think this is the mucoid degeneration of the anterior cruciate ligament with some mucoid cysts at the femoral end. I would refer the patient to the orthopedics for further management. Do you want me to see the contrast as well?
Yes, yes, please.
Okay. Let me see the contrast ones. Okay. So now I'm going through the contrast images. And I can also see that there are something which I have missed in the native sequences. There are certain enhancing lesions in the muscle planes on the posterior aspect, and another enhancing lesion in the anterior aspect of the knee. If I may correlate it with the sagittal again. I'm not really sure, but I think these are mucoid degeneration of the anterior cruciate ligament with perhaps a ruptured, some sort of rupture and mucoid cysts which have interspersed in the muscle planes of the knee joint. The patient would be referred to the orthopedics for the management.
You don't have any other differential for this lesion?
The other differential could be that this is traumatic rupture of the ACL. That is the only other differential which comes in. I do not see any aggressiveness per se to make it a malignant lesion. Another thing which I'm thinking, if there is also, I'm sorry, I think the net is very slow on my side. It seems to be stuck here. It's neither scrolling nor moving to the other one. That's all what we need right now. Laila, can you scroll?
Yes.
Because it's stuck on my side. Oops.
I
Dr.
probably
Laila,
lost connection, sorry.
yeah, no problem. Okay.
So
Can I
I
see
was
the
saying, yeah, I was going
coronal
to say if
fat
you
set?
don't have any differential for this lesion here.
I can hear you. This could be an intramuscular myxoma. One of the differential it could be that. Yes, that's what I can think of.
Okay, fine. So next please.
Okay. Okay. Let me start with the. Should I ask for the control or you will score for me?
Sorry.
Okay, I'll start with the sagittal T2 because that's what's fully loaded. This is the sagittal T2 of the lower cervical and upper dorsal spine. I can see that there is increased signal intensity involving one of the upper dorsal vertebral bodies. And I can see that this altered signal intensity is extending up to the posterior aspects and hence involving the posterior elements. I can also see that there is an extradural aspect, soft tissue density lesion, which is compressing the cord. I'm looking at the contrast enhanced images and it is enhancing intensely. Actually, I should have looked at the axial first before commenting whether this is extradural or intradural. Okay, I think this is extradural. Considering that this is altered signal intensity in the vertebral body and posterior elements, along with enhancing soft tissue elements, I will put a metastatic disease as my first differential. If this is a female, then breast carcinoma would be my prime suspicion. In the male, it would be prostate. Lung cancer could be in any other, in both. I would discuss the findings with the clinician and ask for any previous imaging. And if this is the first presentation, then this patient needs a pan-CT to find out the primary, and mammogram if it's a female patient, and the patient needs to be referred to the oncology MDT for further management.
Okay, so
and of course, the neurosurgical team for the immediate relief of the pressure on the cord. Sorry, Dr. Laila?
No, that's okay. The patient had her investigations and they did not find malignancy.
then this would be strange. Did not find any malignancy. Okay, lymphoma or plasmacytoma, that could be also the differential. So a bone marrow biopsy or biopsy of the vertebral body itself would lead us to the diagnosis.
Okay, very well. Next, please.
Okay, so this is the frontal radiograph of the left shoulder joint, which demonstrates intact glenohumeral articulation. However, I see a lytic focus at the lateral aspect of the scapula, just adjacent to the glenoid cavity. I also have suspicion of a soft tissue density lesion in the left parahilar region. So at the moment, I'm thinking that whether this is a metastatic lesion from a lung primary, and I would ask for a proper chest X-ray to see if there is a lung primary, and if in that case, this patient would go for a chest CT and a chest onco-MDT. To add something, I also feel that there is a lucent lesion on the lucent area in the medial end of the clavicle, which can again be a part of the metastatic disease process from the lung primary. In any case, a chest X-ray and then a chest CT and a staging CT and a referral to onco-MDT would be my next step in the management.
Okay, he didn't have a lung cancer.
Sorry, he did not have?
Chest CT was, yeah, he doesn't have.
Yeah, okay, the chest CT was fine. Okay, so this is something primarily in the shoulder, you mean? But maybe this looks aggressive actually, and because of the multifocality, with the second focus on the medial aspect of the clavicle, even if it's not the chest primary, I would look at the do the CT to see if there is a renal cell carcinoma, which can also lead to lytic expansile lesion and metastatic disease.
He had the CT.
Okay.
I don't think the kidneys were included.
The kidneys were also fine. Okay. So
no, they were not included in the image. That's all.
Yeah. Okay. So I'm looking at the CT shoulder at the moment, and as you said, the chest just have sort of airspace disease or consolidative changes. Here, the scapula and the part of the glenoid is almost, what we would call vanishing here. So the other differential here could be Gorham's disease, the vanishing bone disease in this case. That would be my second differential after the exclusion of metastatic disease. That's like.
Okay. Next, please.
Okay, so this is the AP frontal radiographs of both hands in a skeletally immature patient, which demonstrates multiple lucent expansile lesions involving the predominantly the diaphysis of all the visualized bones of the hands, as well as the left ulna. I'm trying to look at any soft tissue calcic foci in the soft tissue in the hand. I cannot see any. I have also been provided with the lateral aspect of the elbow, which again is full of lucent lesions involving the distal humerus and proximal radius and ulna. In an immature skeleton with such multifocal lesions, the prime differential I can think of is multiple enchondromas or Olier's disease. And because I don't see any calcific foci, so I'm not including the Mehvish syndrome. However, it is first time for me personally to see such enchondromas in the distal humerus and the radius ulna as well. But I'll still keep the enchondromas as the prime differential. There is also periosteal reaction on the left radius and ulna. So in this child, I would ask about if this, very unlikely if this child has a lung neoplastic lesion. What else it can be? Looking at this, it's a picture of hypertrophic osteoarthropathy with these multiple lucent lesions. I'm trying to, classify them into one disease, but at the moment, Caffey's disease would not cause these lesions. Really, I'm at loss here, Dr. Laila, and the time is also up, so
Okay.
I don't want to
Okay.
keep people
So the
waiting.
child is immunocompromised. Does this change your
The child
idea?
is immunocompromised. The child has lymphoma, you mean?
Okay,
I'm
this
not
could be
sure.
one of the differentials, but okay. So anyway, this could also, we could also add the infective etiology, especially when we know that the baby is immunocompromised. So these
Yeah.
are tuberculous lesions. These are
Oh,
widespread TB.
oh, wonderful.
And yeah, they are difficult. So you did put a good differential by saying lymphoma as well. And the presence around the elbow makes enchondromas a little bit difficult. There is also cholesterol action here,
Yes.
but there is also joint effusion here. So
Yes,
there
there
is some
is.
sort of arthritis here as well. So
Right.
this is a widespread bone and joint disease as well. Going for the previous case. You are right. So you are very much right to think about metastatic disease. It's only here. There is nothing in the distal clavicle, and this was renal cell carcinoma. I think here these were not shown on the CT, but I think there could be some pulmonary mets as well.
Okay.
This case, of course, you are right. The first differential that should be borne in mind is the metastatic disease. Lymphoma is also a possibility, but this one was biopsy proven aggressive hemangioma, vertebral hemangioma.
Okay.
Yeah.
Okay. Very nice.
It lacks the usual hyper T1 T2 signal that we are used to for hemangioma, and just carries the usual signal of hypo T1 and hyper T2. That's what makes it difficult to see, and it was biopsy proven only. So even on the T1, it looks like an aggressive lesion. I agree with you.
Right.
And here you are right. So that about the mucoid degeneration, but this one, soft tissue myxoma is a good differential. Also, nerve sheath tumor is also another differential. And this
Which one, sorry?
Nerve sheath tumor. This was the schwannoma of the TB.
Oh, yes, for sure.
Yes.
Okay, thank you. Yes,
it was not seen here. Yeah, it was out of field of view, and this was a mucoid degeneration. Yes.
Yeah.
But obviously, this did not correspond to that patient's pain, so that's why they increased the scan, the field of view.
Yes, very nice, Dr. Laila. Thank you.
Thank you, Dr.
Okay, let me start. So, Bismillah. Okay, Dr. Laila, you can see my screen?
Yeah.
Has the recording stopped? No, it's recording. It's working. Okay. Okay, go ahead, Dr. Laila, your first case.
Right ankle pain with no history of trauma. Okay. So this is a frontal radiograph of the right ankle of a skeletally mature female patient. And I'm checking for the bone density. It looks within normal. I don't see any fracture lines. Joint space appears okay. There is no subluxation. There is a small tiny wave fragment, but this is likely an accessory ossicle. Can I check the other views?
Yes, please.
Okay, so for the mortise view, I can now see that there is an lucency that is seen in the talar dome, medial side of the talar dome, and
yes. Can you please point it out?
Yeah, this one. You can see my.
Excellent. Yes.
Yes. Okay.
Good.
So this is much likely to represent an osteochondritis dissecans of the right talus. For that case, I would recommend refer the patient to the orthopedic team. She will need an MRI for further grading of the lesion, which will control her management.
Okay, excellent.
Neck pain, 35 years old male. Okay.
Go ahead.
Okay, so this is a sagittal MRI, sagittal and axial MRI scan of the neck, and I can see. I feel there is some fusion of the vertebral bodies anteriorly as well as in some point there is posteriorly as well.
Excellent.
Yeah, at this point, so the vertebral bodies are fused together, and this is seen at multiple levels. So this patient seems to be having, given that he is a young age, he seems to be having a Klippel-Fehl syndrome. I will revise other images to confirm.
Can you look at all the vertebral bodies very carefully? You're right about the appearance of fusion. Yeah.
Okay. There is one of the vertebral bodies shows an abnormal segment density lesion. Let's see, 2, 3, 4, 5, 6, 7, and G1. T1 so it shows a lesion here, a medullary lesion that is hyperintense on T1 and hyperintense on T2. And okay, so this is coming in an anterior corner. It could represent the shine, we call it the corner shine side, or Anderson side, I think, Anderson lesions. I would be doubtful that this patient may be having ankylosing spondylitis. For him, I will check his previous imaging studies, particularly for the lumbosacral spine and both sacroiliac joints, to check if they are affected by ankylosing spondylitis or not. And then I will refer him to the rheumatology team for further management.
You want what imaging? The MRI imaging?
X-ray, even X-ray or CTs.
Very good. Okay. Here you go. See all the X-rays you need to see, and just keep describing whatever you see, please.
Okay, fine. So I'll start with the lateral view. So the lateral view of the cervical spine does confirm that all the vertebrae are fused together with extensive syndesmophytes, and the entire spine is fused together, confirming that this patient is having ankylosing spondylitis in an extensive degree. I will also confirm on the AP view of the dorsal spine, and there we can see also that there is calcification of the interspinous ligament, giving the characteristic dagger sign. For the lumbar spine, I think it's a poor image quality, but yeah, it seems to be less significantly affected than the dorsal spine. But the dagger sign is still positive. Right. And I think the sacroiliac joints are fused. So yes, for this patient, it confirms that this is an ankylosing spondylitis, and I will need to check if the patient is having fractures or not, pathological fractures, by having a CT of the spine.
Can you tell me it's association of ankylosing spondylitis, like it's a multi-system disease? So anything else you would like to think?
Patient could be having some gallstone disease. He could be having ulcerative colitis, inflammatory bowel disease, ulcerative colitis, or Crohn's disease. Not to mention the pathological fracture.
Let's go to the next case. Okay.
Headache, nausea, post-nasal discharge. Okay.
So spot diagnosis. No need to describe.
Okay, this is an ivory osteoma in the frontal sinus.
Excellent. What's the association of ivory osteoma? Can you think of any syndrome with what it is associated?
The syndrome of multiple, for me, they know it's periposis coli, but I don't remember the name.
No problem. Okay. Go ahead. See any X-rays you need. This is review in the clinic.
Just review? Okay.
Yeah.
So this patient, this is an X-ray of the radiograph of the right foot in a dorsoplantar view, and patient seems to will be having long metatarsal bones. I wonder if he's having arachnodactyly, maybe. There is also a malalignment of the tarsometatarsal joints at the first and second, probably also the lateral metatarsals. If the patient doesn't have, patient if he has history of trauma, then I would be doubtful that this is, it's on the left side as well. Okay.
There is no history of trauma.
So, okay, so there is laxity of the left frank ligaments here, leading to the lateral dislocation or subluxation of the tarsal joints, and on the left side it is divergent. So the first one goes medial and the lateral four goes laterally. So the patient having long metatarsal bones and he's having laxity of the ligaments, and I think he's having arachnodactyly or Marfan
No
syndrome.
arachnodactyly. No arachnodactyly.
Sorry, not arachnodactyly.
Yeah. Can you describe the changes in the left foot for me, please?
Okay, so this is the oblique view. So there are arthroplastic changes here in the first tarsal joints.
Right.
There's subluxation in the joints as well.
Okay, Lisfranc, I agree. Anything else? If no history of trauma, can you think of anything else?
There could be some joint destruction here as well. So the patient could be having also like peripheral neuropathy. So this could represent the Charcot joint.
Charcot joint, excellent. Okay, next please.
Pain, no trauma, 40 years old. Okay.
Yeah, go ahead.
Okay, so I'm presented with a frontal radiograph of the pelvis and both hip joints, and I can see that the right femoral neck and upper shaft is diffusely enlarged with multiple lucent lesions within, and it is distorted in shape. Similarly, similar lesions are also seen in the right hip bone, at the rim, and in the acetabulum as well. So I have two differentials here for this lesion. Either it is fibrous dysplasia or Paget disease, but Paget disease does not usually give this pattern of multiple lucents. It's usually more confluent.
So what do you think?
It's also extending along the shaft. So I will put fibrous dysplasia as a beginning, as my first differential diagnosis.
Okay. Does it support your diagnosis?
Yes, being in multiple bones and this pattern of appearance, it's polyostotic fibrous dysplasia.
Go ahead. Now look at the coronal stir and then go to any contrast enhanced. Go ahead.
Okay, so this is the coronal MRI scan of a fat suppressed T2 of the post femora, and it confirms the similar findings and similar findings to those in the radiograph.
Right.
So I'm looking for any extra osseous extension of lesions. There are some here soft tissue lesions seen in intramuscular in the posterior aspect of the thigh. So these could represent soft tissue, what's it called, myxomas, soft tissue myxomas in a patient with polyostotic fibrous dysplasia. So I will check. Okay.
Good that you picked this as well. Yeah, go ahead. What's happening here?
So this is, there are multiple fluid levels seen in these lesions. So these could represent an aneurysmal bone cyst. However, aneurysmal bone cyst can also occur as a secondary pathology in addition to the primary pathology of the bone. So I still believe that this patient is having polyostotic fibrous dysplasia, soft tissue myxomas, and complicated by the development of a secondary aneurysmal bone cyst in the right femoral neck.
Excellent. Okay, can I take the mouse? Our time is up. I'll just start with the review. So, okay, you are right that this is polyostotic fibrous dysplasia, and you rightly picked out the soft tissue myxomas. So this is the Maza-Brod syndrome. And this is, you rightly picked up fluid level, aneurysmal bone cyst, and aneurysmal bone cyst can happen with the underlying fibrous dysplasia as well. So rightly said, fibrous dysplasia, intramuscular myxoma, cystic degeneration with aneurysmal bone cyst in collaboration, okay? This I showed you, and I said you multiple times, the reason that there is no history of trauma, but you rightly picked up the Lisfranc dislocation, yes, but this is the, as you said, that this is Charcot, okay? So whenever we see such sort of Charcot and this Lisfranc, It's always nice to say, those buzzwords we all know, the density change, the destruction, the debris, the disorganization, the dislocation. So this is the shortcuts. And for the causes, as you rightly said, diabetes can be one of the reasons. Syphilis, we see it in the shoulder, right? Steroid use, syringomyelia. So all this is shortcuts, okay? Next, we had this ivory osteoma. You rightly said the polyposis one, that's the Gardner syndrome, in which we have the polyposis, intestinal polyposis, the desmoid tuber, and the osteoma. Okay, so that was also fine. Coming to this ankylosing spondylitis, very rightly picked up. I always get confused with this Romanus lesion, this shiny corner sign, and this Anderson lesion. Okay, so I just read the core before this. So the Romanus lesion is actually the active lesion. Okay, any active lesion would be hyper intense on T2. So this one that is hyper on T2 and hypo on T1 is the Romanus lesion. When this Romanus lesion heals, that is, there is sclerosis, then it becomes the shiny corner sign. Okay, and the Anderson lesion is actually the pseudoarthrosis, which develops in this completely ankylosed spine. So these are one of the terms which we have to keep revising, because these really become confusing, but rightly said. This one, you nailed it. As we saw in the previous sessions, as previous hot seats as well. If you cannot see anything in the AP, it's your job, my job to ask for the next view. Okay, the examiner will not show me the next view if I don't ask for it. If I keep stuck there, he will keep me stuck there. So you rightly asked for the one, and very nicely picked up the tetanus osteochondrosis dissecans. And yes, I really like that you said that I will do MRI for the staging. So whenever you ask for the next, next phase, next imaging, justify why do you need it for. So very well done, Dr. Laila. Thank you so much. Dr. Rohit and Dr. Maimoona, you are next. Dr. Rohit, you can start sharing the screen. Dr. Maimoona would go first.
Hello.
Hello. Yes. Go ahead.
Yeah. I shall examine, or I think.
First, you can examine, and then in the end, Dr. Maimoona has started. Okay, go ahead, Dr. Maimoona. You can examine Dr. Rohit. Let's go.
This is your first case, Dr. Rohit.
Yeah. Yeah. So 30-year-old female with pain and deformity of the wrist.
Yes. Can you see the X-ray?
Dr. Rohit, are you with us?
X-ray.
Yes,
so,
go ahead, please.
Yeah. Can you hear me?
Yes.
Hello.
Yes, we
start
can.
speaking.
Yeah. This is the frontal radiograph of a wrist of a 30-year-old female who has presented with pain and swelling of the wrist. I can see that the distal end of the radius, including the metaphysis and epiphysis, it shows an osteolytic lesion with cortical destruction, and there is extension up to the articular surface, and I can see the soft tissue component. There is soft tissue swelling, and so my differential diagnosis for this age would be first of all giant cell tumor, and then the other thing I would consider is since the lesion appears to be locally aggressive, there might be some other lesion like metastasis or myeloma, although at this age group that seems less likely. And I would want to take this further by doing an MRI to look for full levels.
Next case.
Okay. So this is the next. Is this the next case?
Yes.
Yeah.
It is
So
the
this is a
next case.
30-year-old male, night pain. Yeah, night
Yes.
pain subsided by analgesics for the last few months. Okay.
Can you see the X-ray?
Yeah. I can see. So this is the X-ray of the femur of a skeletally mature patient, and I can see that there is a cortical thickening in the diaphysis of the femur, and with this clinical feature, my first differential would be. I just want to describe the lesion further. So this is a lesion with the wide zone of transition, and I cannot see any periosteal erection, and the other cortex remain normal. Is normal. There is no significant associated soft tissue component. So with these features, I cannot see any chondrite matrix or any cortical break. So with this description and the clinical history, my diagnosis would be osteoid osteoma. And I would like to take this further by doing an CT of the patient to look for
Anything you want to include?
the lesion in the cortex. Pardon?
Any
Okay.
other differential you want
So,
to include in that case?
Okay. The differential I would like to include is stress fracture, which can present with such a periosteal erection.
Okay. Next.
So a 5-year-old girl. Okay. No history of trauma. 5-year-old female. Okay. Please show me the imaging studies.
Okay.
I can see that in the hand of an immature patient, there are multiple radiolucent lesions involving the multiple bones, that is metacarpal, phalanges, and distal end of ulna. These lesions are slightly expansile, and these mainly involve the metaphyseal lesions. Are there other views or other X-rays? So I just want to look at whether the lesion is. Oh, so there
Only
is
X-rays
no
available.
involvement of the other. Okay. So there is some sort of Madelung deformity, and this seems to be some disease like multiple osteochondromas or
Any other differential?
the other differential would be some aggressive lesion like leukemic infiltration, which has led to such destructions. So we would like to take this further. Okay. 30-year-old male with 4 weeks of bilateral pleuritic chest pain. Okay. So I can say that bilateral pleuritic chest pain. I can see that there is no obvious abnormality in the lungs or heart. Now I am reviewing the bones.
Concentrate on the
In
spine.
the bones, okay. Yeah, there is some destruction of this vertebra. I'm not able to see the pedicle and right lateral part of I think the L1 vertebral body, and the CT scan which is provided to me. Yeah, can I see the SAG reconstructions?
Okay. You can scroll it, or you want me to scroll it?
Yeah, there is some irregular osteolytic lesion involving the vertebral body, and yeah, it involves the vertebral body, and there is no extension to the pedicles. Yeah, there is also involvement of the skip lesion is also seen in the other vertebral body, which involves the pedicle. So this is a multifocal process which involves multiple vertebral bodies. So it could be either metastatic lesion or it could be multiple myeloma. I would like to any other differential. It could be infective process like tuberculosis, which can have such multifocal appearance. And I would like to take this further by advising, discussing with the orthopedics and going for biopsy of the lesions.
Can you see my screen?
30-year-old male. Okay. Right shoulder pain and limited range of motion in a 30-year-old male.
Just to let you know, this would be the last case, okay?
Okay.
Okay. So this is a 30-year-old male with the limited range of motion. I can see that the scapula, the subchondral region of scapula involved. There is an multicystic osteolytic lesion with septa seen. So the lesion is expansile and it has a narrow zone of transition. So I am suspecting I cannot see any matrix in the lesion, no associated soft tissue component, and it seems to me that it is a benign lesion, likely GCT, which can lead
Any
to
other
such things.
differentials?
And I would like to take in a few skeleton, there is a little possibility of ABC. Apart from GCT, it could be some infective process like tuberculosis can have this appearance. And
So what will you do next?
so I would like to take this further by doing an MRI to look for the internal characteristics of the lesion. I cannot see any lesion in other bones.
Okay. You
The humerus.
the final diagnosis of this case was chondroblastoma, but your differentials were fine. It can be a giant cell tumor, and also ABC is this skeleton.
Okay.
Rest of your diagnoses all were fine. You did well in all your cases. And the first one was giant cell tumor of the wrist.
Okay.
This one. And the next one was osteoid osteoma of the femur in a young patient. And your diagnosis was right. These are multiple end chondromas, and along with this there is Madelung deformity. So, your differential was fine because you suggested I think multiple end chondroma, osteochondromas, but these are all benign looking lesions, so you were on right. And in this case, it was pretty hard to detect the lesion on the chest X-ray, but ultimately you picked it, and on CT scan you were fine, and the differentials are metastasis, multiple myeloma, and tuberculosis. But this was diagnosed as tuberculosis.
Okay.
And, next was I think this one I told you the diagnosis. The diagnosis was chondroblastoma.
Okay.
And stop sharing.
Okay, thank you, Dr. Maimoona and Dr. Rohit. Dr. Rohit, you can go ahead and now examine Dr.
Yeah. So these are the cases. These I have collected from my hospital. So I think I have tried to pick some good cases. So I hope you all will like this. Can you see my screen?
Yes.
This is a 53-year-old male with progressive swelling few years, for past few years in the great toe. Okay. So this was the X-ray of the foot. He has progressive swelling of the big toe.
Okay. Okay, these are frontal and oblique projection radiographs of a 53-year-old patient who has presented with swelling of the great toe. I can see that there is significant soft tissue swelling at the base of the great toe, and however, there is some compression or deformity of the underlying proximal phalanx. The joint spaces are intact. The joints are normal. There is no air lucencies within the soft tissue swelling, and there are no similar soft tissue swellings seen in the rest of the radiograph. The distal phalanx of the big toe appears slightly irregular in outline. So this can be an inflammatory process, which might be involving the soft tissues and also the bones. However, the patient has a very long-term history.
The patient has long history, ma'am. It is progressing for the last few years. Okay.
Okay, so it can be a soft tissue lesion, which can be benign origin because it's and causing some compression over the proximal phalanx. And I'll suggest an MRI to further take to narrow my differentials. But it is a soft tissue
lesion. Any other
lesion.
modality, ma'am, which can be done? Any other modality?
CT scan.
Apart from MRI, any other modality?
CT scan.
Soft tissue. CT scan.
Ultrasound. Can we
any
do
other
an
thing
ultrasound?
from CT?
Ultrasound.
Yeah. I have done an ultrasound, and please see the images of ultrasound. So FHL is flexor hallucis longus tendon. Huh? So this is the tendon which you can see. Okay. So this is the lesion. So please describe the lesion.
So this lesion is lying anterior to the flexor hallucis longus tendon, and it is heterogeneous and hypoechoic in appearance, and lying in the subcutaneous tissue. So this can be a benign lesion, and I'll like to put a Doppler color flow in the lesion, and it can be a hemangioma, or it can be any other soft tissue lesion, but it is probably of benign origin.
Okay, there was no significant color flow in the lesion, although there was vascularity, but not as much as of a. It was not a vascular lesion. Any other possibility, ma'am?
It is predominantly hypoechoic in appearance.
Yeah, it is intimately associated with or
Morton's neuroma,
related to tendon.
Morton's neuroma. Can it be a Morton's?
No, see the size of the lesion. So it is longitudinally oriented along the tendon.
Yes.
So anything which any lesion which
can
is
it be a giant cell lesion of the tendon?
Yeah. It was GCT of the tendon sheath. Okay. I'm going to the next case, ma'am. So the case 2 is 32-year-old female with pain, ma'am. So
32 years old
she
female.
came with vague abdominal pain on right side. Yeah, 32-year-old female with pain. So this is the abdominal X-ray which was done, ma'am.
Okay, this is a frontal projection radiograph of abdomen of a female patient who is presented with pain. And the most striking abnormality which I can see are some soft tissue lesions overlying the right iliac bone and also projecting at the right anterior superior iliac spine. There is some loss of joint space at the sacroiliac joint on the right side. Looking at the
So ignore this joint space finding, ma'am. Please concentrate on the lesion and the morphology of the
this
lesion.
can be this lesion can be a bony lesion, and it has an irregular margins and closely associated with the right ileum. It looks like an a lesion with a narrow zone of transition, and there are multiple in origin, like T2 of them. So these can be osteochondromas. Can these be osteochondromas?
Yeah, they can
But
be.
have,
So
yeah, but
how
the
okay.
has a very large soft tissue component, which I can see projected over the right side of the abdomen. So can this be an abdominal lesion because she is a 30-year-old female? So can this be a dermoid tumor? Because and these lesions can be intradermoid calcifications. So I'll suggest
dermoid at this site. I think. How would you like to take this further, ma'am?
Like I'll suggest CT scan abdomen to.
Okay. I'll just give you the CT scan.
Okay. This is a destructive lesion of the right ileum with a very large soft tissue component projecting anteriorly, and so this is an aggressive-looking tumor. And arising from the right ileum with a large soft tissue component. So keeping in view the age of the patient, it can be an osteosarcoma. And it can be a metastasis. Yeah.
So this is the bone window.
Yes, it can be an osteochondroma, which has with malignant degeneration into a chondrosarcoma, keeping in view this polypoidal appearance. And
can you see some other lesions? Can you see some other lesions?
Yes, I can also see there are some soft tissue lesions scattered anterior to the sacrum in the pelvis. This can be metastatic lymph nodes.
Okay. So what are these lesions?
Yes, there are multiple lucent lesions scattered within the pelvic bones. So these can be metastases. Or these can be enchondromas, multiple enchondromas.
Any other possibility, ma'am?
No.
Any other
I cannot.
Any other syndrome? Okay. So what are these calcifications in the lesion?
These can be. These can be due to metrics of the ins and outs, like calcification scattered within the soft tissues. So it can be a chondroid origin.
Okay, Dr. Rohit, Dr. Maimoona, the time is up. Okay. I think you can start the feedback. Yeah, sure. Go ahead.
Yeah. Can I? Okay, but can I discuss one more case, because I have collected at least, or I will just show you one more case too, ma'am.
Sure. Go ahead.
Okay.
We will discuss this further, ma'am. Elderly male, there is recent history of cholecystectomy presented with back pain. So this was the X-ray of the spine, which was taken. He is 60-year-old male, man.
Okay, this is a frontal projection radiograph of a male patient who has a previous history of cholecystectomy, I can see polycystic in the right hypochondrium, and what I can see is lucency scattered over the right hemi-abdomen, lateral to the psoas outline, and
So any lesion in the lumbar spine, ma'am?
yes, the vertebral bodies are of normal heights with normal pedicles. However, there is I cannot appreciate the right pedicle of the and also the transverse process of the L3 vertebral body.
So how would you like to take this further, ma'am?
I suggest an MRI to take my case further.
Okay. So this was the CT scan which was done, ma'am.
Okay. So on this, on these selected images, I can see that there is a destructive lesion involving the body and the posterior elements of the respective vertebra, and there is also destruction of the transverse process, the lamina and the pedicle. So this appears to be an aggressive process, and I'll be concerned regarding the intraspinal extension and some epidural component if there is any. So I suggest an MRI, lumbar spine with contrast to look for intraspinal component, and scan the rest
This
of
was the MRI which was done, ma'am. This was the MRI which was done.
Okay. So these are sagittal MR images. First one is T1 post contrast. Second second one is T2, and the third one is fat sat image. And I can see that there is a similar process can be seen in multiple vertebral bodies involving L3 and L5 vertebral bodies with involvement of the posterior elements. And however, on these images, also down of the S1 at the level of S1. However, I cannot see any intraspinal component, any epidural component of these lesions, and the corner nerve roots are can be seen normally. So this appears to be a
what is your final diagnosis?
Process can be metastasis, or my primary differential will be metastasis. It can be multiple myeloma, or it can be any inflammatory process. The lower down differential will be tuberculosis. It can be lymphoma.
Yeah, it was metastatic bony lesions. Okay, ma'am. So this was osteochondromas, which you can see. This is one osteochondroma. This is second osteochondroma. So this was chondrosarcoma. So there was a malignant degeneration of an osteochondroma. So multiple osteochondromas, diaphyseal ecclesis. Okay, ma'am. Hello. Can you see me?
I can.
Excellent.
Yes.
Yeah. So this was the soft tissue component with the rings and arc pattern of calcifications, and presented as an abdominal mass. So this is the soft tissue component of the lesion. The other osteochondroma which is benign, and there was an osteochondroma which has undergone malignant degeneration. So which is presented with soft tissue component and pain in the pelvis. So this was the hypoechoic giant cell tumor, GCT of the tendon sheath. So that's why it is oriented along the long axis of the FHL tendon. So which was seen as a soft tissue component of the great toe. Is that fine, ma'am?
Yes.
It's excellent. Thank you so much, everyone. Excellent
Dr.
cases.
Sabahat, I have, yeah, there is one or two more interesting cases. I just want to go through them so that
Dr.
you can
Rohit,
see all
maybe
of those.
Dr. Rohit, maybe next time. No, we are already 10 minutes ahead, and everybody. But thank you so much for bringing such excellent cases.